So the next presenter is Dr. Kharosek. He will present his talk on minimal access spine surgery, mastering the learning curve. Can we hear from Dr. Kharosek?
Good afternoon, everyone. I'm Dr. Hrushikesh. I'm the Associate Professor in Department of Neurosurgery at Grand Government Medical College, Mumbai, and I'll be speaking on minimal access spine surgery, mastering the learning curve. So this is the institute where I work as Associate Professor. So coming to introduction, the spinal surgery all over the world is undergoing a revolutionary change in terms of biomechanical concepts, motion preservation, and tissue preservation. Growing number of spine surgeons are now using MIS techniques, minimal invasive techniques, to treat the wide range of spinal pathology that traditionally we treated with open surgery. The progress in technology, more sophisticated instrumentation devices have paved a way for better visualization and management of the complex spinal conditions by minimal invasive approaches. The middle-aged spine surgeon, which was earlier familiar with the open surgery, needs to put an extra effort to change from maximal to minimal invasive spine surgery. So what were the advantages of axial invasive spine surgery? There was more visualization of underlying points like Mercedes-Benz signs. Multiple level spinal pathology could be dealt with a single incision, and there was less C-arm exposure or radiation exposure. The drawbacks were there were bigger scars, there was muscle cutting, there was muscle fibrosis, biomechanical instability with acid damage, the post-operative pain, longer hospital stay, and higher morbidity. So what are the prerequisites for minimal invasive approach? Is thorough knowledge of the anatomy, thorough knowledge of the biomechanics of the spine, understanding the disease process, making right choice in right patients, familiarity and mastery of the tools, and learning the curve from maximal to minimal approach. So minimal invasive spine surgery includes microscopic approaches, endoscopic approaches, percutaneous, or combination, that is hybrid techniques. So what are the limitations of this minimal invasive approach? Multiple level involvements, grossly unstable spine, larger tumors, infective vascular lesions can be difficult to manage with MIS. The disadvantage, it requires more expensive equipments, instruments. It takes more time initially, it requires a proper setup, proper tools. It is significantly technology dependent, it is expensive, and there is more radiation exposure. So what are the ways to go develop into a minimal invasive spine surgeon? Is you have to start early into minimal invasive surgery, early in your practice, learn it transsphenoidal way, attend cadaveric workshops, attend fellowship workshops, assist an expert in minimal invasive surgery. It is better always to have an expert in minimal invasive surgery as your assistant in OR initially, and you have to be familiar with the tools. The requirements for MIS are a good setup. All the equipments, the staff, assistant, and technicians should be familiar with the approach. There should be training in labs, cadavers, and spine models. So what are the minimal invasive approaches? For cervical spine, there is anterior and posterior approach. The anterior cervical microforaminectomy and endoscopic assisted anterior cervical discectomy are the familiar anterior approaches in MIS surgeries. But as everybody knows, anterior cervical discectomy is already a minimal invasive open procedures, and the lack of expected results in CHO procedure has impeded the widespread use of this anterior minimal invasive approach for cervical spine. The posterior approach, that is posterior cervical microendoscopic foraminectomy approach, is very familiar, and many of the spine surgeons use this for cervical spine. And definitely multiple studies have endorsed the advantage of this approach over the open approach for posterior cervical pathologies. That is because in open posterior cervical approach, there is a lot of muscle cutting, muscle dissection. It gives post-operative neck pain, and there is blood loss as well. And there are chances of injuring the venous plexus or vertebral artery. So posterior cervical microendoscopic foraminectomy is definitely being used by many of the spine surgeons. The thoracic spine, the minimal invasive anterior and posterior lateral approaches have been developed for thoracic disc herniation, but still there is absence of randomized controlled trial comparing this with the open approach. The key factor in developing minimal invasive approach for thoracic spine is the comorbidities associated with the larger thoracotomies. The thoracoscopic approach was developed to replace this, but it has gradually subsided because it needs a lot of expensive instruments, and the learning curve is quite steep in thoracoscopy also. So mini open lateral approach, which I'll be showing in one of the cases which we have done, is a middle way ground between endoscopic approach and the open approach. Thoracolumbar fractures are very common problems which are encountered by the spine surgeons. The minimal invasive approaches definitely reduces the complications, but there are only 2 or 3 studies available in literature which compare the results of open and minimal invasive approach for thoracolumbar fractures. So definitely for more use of minimal invasive approach in this, we need a lot of high quality prospective trials. So coming to lumbar spine, lumbar microdiscectomy. This is the most common condition in which the minimal invasive approach has become famous for. It has the advantages of less muscle dissection, less blood loss, early recovery, less post-operative pain, and early discharge of the patient. But in literature, when the results were compared by multiple trials, there was not much of a difference in relief from radicular pain by both the approaches, open as well as minimal invasive approach. They didn't find any difference. But ultimately, the truth is that the benefits of MIS are unlikely to be realized in lumbar microdiscectomy, as already in lumbar microdiscectomy, the complication rates are low, there is morbidity is low, there is early recovery, and patient is discharged fast in open technique as well. The other point to be keep in mind is minimal invasive technique for lumbar spine are also relatively new, and it takes a significant learning curve. So the complication rates might be higher in early part of this learning curve. So there's slight bias in these studies. So definitely minimal invasive approach is more commonly used in lumbar microdiscectomy. Coming to lumbar canal stenosis, which needs open lumbar decompression or laminectomy. The post-operative spinal instability is a concern when the patient undergoes a laminectomy for lumbar canal stenosis, especially when there is slight spondylolisthesis. So minimal invasive approach maintains the posterior tension band, preserves the passage joints, minimizing the risk of post-operative instability in these patients. So even though multiple trials are being done to compare the results of open and minimal invasive approach for lumbar canal decompression, they are still at the level 2 and level 3 evidence. But still, unilateral laminotomy or interlaminal laminectomy for bilateral decompression has become the minimal invasive procedure of choice for many of the surgeons for lumbar canal stenosis. For spinal tumors, minimal invasive approach definitely reduces the blood loss, post-operative pain, and the functional recovery is early when compared with the open approaches. For intradural lesions, the studies are still lacking, but it is very much commonly used now, especially in lumbar region where there is a lot of space. So now coming to the learning curve for minimal invasive approaches. So the learning curve is there to be mastered in minimal invasive spine approaches, techniques, and the technology for safe and effective utilization of these techniques. And this can be achieved with class studies, cadaveric labs, fellowships, experience in operative theater with an expert in minimal invasive spine surgery. However, it is important to carefully select the patient, do a proper patient workup in providing the effective minimal invasive spine care. So why there is a learning curve in this minimal invasive approaches? The MIS generally requires a unique technique or modified tools, and you have to there is need of acquisition of new skills. It represents a departure from traditional surgery with regard to operative view and approach to the anatomy. The anatomy is very limited in exposed compared to open techniques in minimal invasive techniques. As a result, the operative time may be initially very high compared to the operative time. Those who are experienced in minimal invasive techniques will caution that there is significant investment of time and patience from the young surgeon is required before the benefits of MIS can be realized, as a learning curve is steep. proper understanding of the fundamental differences between MIS and traditional surgery, as well as the similarity, serves the basis to overcome this learning curve. MIS represents a departure from traditional spine surgery in regards of the intraoperative image guidance and association with endoscopy, microscopy, increasing the work distance, different surgical view, narrow working channel, and modified instruments. So attention to all these unique aspects of MIS and their advantages as well as limitations is paramount important in overcoming this learning curve. So how do we overcome this learning curve as a young neurosurgeon? First step is doing cadaveric training. Attend the cadaveric labs, cadaver workshops done by expert in minimal invasive techniques. Operative training, you have to attend the OR for gaining most of the experience. So you have to undergo residency programs and fellowships in minimal invasive surgery. Indications and contraindication of each approach has to be thoroughly learned, and you have to cross-check them every time you approach a patient or plan a patient for minimal invasive approach. Patient selection is at most important. You have to consider both the approaches, open as well as MIS for the patient. You have to check the risk and benefit, as well as you have to check the surgeon's comfort and comforts and experience in that procedure. Pre-operative planning is at most important. You have to do a pre-operative planning. You have to plan how you are going about, how you are doing it, how you are going to handle the complications. The instrumentation, you have to know what are the instruments, what are the tools necessary, and those should be arranged in advance. Patient positioning carries the utmost important in minimal invasive surgery. So you have to know what is required for patient positioning, which position has to be given, knee chest position, what are the beds required, and you have to arrange them pre-operatively in advance. Surgical approach is very important, and a facial incision, that is what is different from the minimal invasive approach compared to the open approach, as it prevents the muscle dissection and muscle injury. So facial incision has to be proper. Coming to the surgical technique, smaller incision, smaller incision. What makes the difference for the patient as well as the surgeon? So selecting the appropriate location of incision is very important. So you have to spend extra time. You have to double check, triple check the location and relevant landmarks of the incision, as the working channel will be narrow. So small deviation in the ideal location of incision can make life difficult intraoperatively. The working channel is what differentiates the minimal invasive approach from the open approach. So working channel has to be properly planned under the C-arm guidance. It will split the muscles and not cut the muscles. So that is what prevents the muscle injury and the post-operative pain. So the K-wire, as you have to see under CIM guidance, has to be docked right on the lamina. You have to plan the length of the working channel. A narrow working length can lead to the soft tissue muscles coming between the view, or a longer than needed working channel will lead to different angles and different manipulation intraoperatively, which can make life difficult for you. The view is very different in minimal invasive surgery compared to open. The view is narrower, and for that you have to review the anatomy pre-operatively. You have to take it in mind sometimes the points which will not be seen in minimal invasive, but which you have experienced in open surgery. And another point which differentiate is lack of the depth perception in minimal invasive surgery. Post-operative care, as always, the recovery is early. There is less post-operative pain, so early discharge can be planned in minimal invasive approaches. And the other aspect which has to be dealt with is complications. So sometimes these complications might be difficult to handle, like dural tears. In the narrow working channel, it can be difficult to repair the laterally placed dural tears. But with the advent of dural substitutes like one pericardial patch or Duragen, dural and Dura clips, now it has become quite easier